Hope that we are all keeping well. Welcome to our webinar today, Beyond Policy to Practice, County Experiences in FIF Implementation. We are quite interested and excited to be having this discussion as we seek to learn from Nairobi City County and Trans Nzoia County on the progress that they have made in terms of the FIF Act implementation and the progress that they've made in terms of domesticating the Act, because as we are aware, the National FIF Act does provide for counties to domesticate this Act to allow it to fit their local context. So we want to see what Nairobi City and Trans Nzoia have done and what other counties can borrow, what's working, what's not working. And so without much further ado, I will invite Dr. Zaituni to walk us through a short presentation. And as she does that, I request that Dr. Zaituni, you also introduce yourself and let our audience know who you are and what you do. Karibu sana.
Thank you, Gladys. My name is Dr. Zaituni Mula. I'm the primary healthcare coordinator for Trans Nzoia County. It's quite a privilege to have all of you on board. Today we will be discussing county experiences in FIF implementation. With me, I have two other colleagues who will participate in the panel discussions to beef up the experiences that we've had in both Nairobi County and Trans Nzoia County. So just as a background, in 2017, the former administration, through His Excellency, the former President Uhuru Kenyatta, the country came up with the Big Four agenda. The first one was manufacturing, the second one was affordable housing, and then we also had universal health coverage and food security. So as part of the Big Four agendas, the new president continued with implementation of the universal health coverage through enactment of the four acts. The first one was the Primary Healthcare Act. The second one was the Social Insurance Act, the Facility Improvement Financing Act of 2023, and the Digital Health Act. The four acts were very key in the implementation of universal health coverage in Kenya in this sense. So the Primary Healthcare Act was supposed to ensure that we cascade healthcare services throughout all the levels of care, from level 1 all the way to 5. And then the Social Health Insurance Act was to ensure that we reduce the out-of-pocket expenditure to offer quality healthcare services. And the Digital Health Act is the one that ties in all these acts. Is the Social Health Insurance Act requires digitization of the healthcare services to ensure that you are able to claim for the finances once you have offered the service. So the FIF Act aimed to enhance the financial autonomy for health facilities across all the counties by allowing them to retain the finances that they would have generated through the various revenue streams. So what was the practice prior to the enactment of the FIF? You would ask yourself. So before devolution, health facilities used to retain the that they would have generated through the user fees and other insurances like NHIF, and then utilize those resources to offer services to the people. But after devolution, the facilities were required to remit the money that they would have collected in a pool account, which was the County Revenue Fund. This was in line with the PFM Act of 2012. But that was not allowing the facilities the autonomy to maybe buy commodities, to offer other services that would have required them to use the money at the facility. So this led to very weak structures in the healthcare facilities, both at the both in the lower level facilities and the higher levels, and it delayed responsiveness to emerging needs at the facility level. So through the enactment of the FIF Act in 2023, the legislation promised us several things. That one, there would be a clear and uniform guideline which would allow health facilities to retain and manage their own revenues in the facilities. And the revenue streams included the on-source revenue. This included the user fees, charges, and the insurance reimbursements. Initially, it was the NHIF. Now we have the SHA reimbursements, and then the county government allocations would also be part of the revenue stream that the facilities would also use, and additional conditional grants like the DANIDA and donations and gifts from our other healthcare partners. So this would have now ensured that the facility had an accessible revenue stream and a more predictable flow of funds to the primary healthcare facilities. This also reduced the diversion of funds, which was very common in the counties. Even here in Trans Nzoia, it was quite a challenge. The money would be collected in a pool account, and then it would now eventually be used for other uses other than offering healthcare services. We also have such experiences from other counties like Kilifi. We also have the same experience in Nairobi County. I think the other two panelists will be able to also outline some of the challenges that were also experienced by pooling the monies in a pooled account. So this also ensured that there was a stronger facility accountability, because one of the items in the FIF Act is that the facilities needed to have boards of management, which would ensure accountability, proper planning, and proper use of the finances once they're disbursed. So what is the journey in Trans Nzoia? Just as a snapshot, in 2021, we enacted the first FIF Act, which had the regulations of how the finances would be used, leaving 70% of the revenue collected at the facility level for expenditure, and then 22% was being used for financing PHC activities, 3% was used for management of the facility boards, and 5% went into research. However, in 2023, we had the National FIF Act, which was supposed to be a model FIF for all the county governments. So Trans Nzoia County moved from the previous regulations to now having the facilities retain 100% of the money and then budgeting appropriately at the facility level. So again, my name is Dr. Zaitunia Kadureit-Mula. Thank you very much. I have come to the end of the presentation. I would take it back to Gladys. Thank you.
Thank you very much, Dr. Zaituni, for giving us the overview of the FIF Act. And we can already see some of the changes that came up in response to the national level FIF Act. We've seen the past experience with Trans Nzoia, past provisions versus what we currently have in response to the national act. So we will proceed on to the panel discussion, and allow me to ask our panelists to first introduce themselves. And I say ladies first, a little biased, but Dr. Rebecca, you could introduce yourself in less than a meeting. Sorry, less than a minute, sorry.
Thank you, Gladys, for that. And I agree, ladies first. Yeah. So my name is Dr. Rebecca Musyoki. I'm a pharmacist by profession in Nairobi County. I lead health financing, and we just take care of two things in health financing. We are all about more money for health and more health for the money. Thank you.
Amazing, love that. More value for money, value for more money for value. Amazing. Over to you, Dr. Babu.
Thank you so much, Gladys. My name is Isaac Babu Kisiangani. I'm a psychiatrist, and I believe in transforming public healthcare systems. I'm the County Director of Health, Trans Nzoia County.
Thank you very much, Dr. Rebecca and Dr. Babu, and Dr. Zaituni as well. I think I need to become a doctor at this point. So we will head into the questions section, and I think it's only fair for us to start with a big picture. So we want to see and hear what has been the progress that both Trans Nzoia and Nairobi City County have made since the enactment of the FIF Act 2023 at the national level. Have you been able to domesticate the act? If yes, well, how was the process? If not, what stage are you at in terms of the domestication process? Dr. Rebecca, we can start with you.
Thank you, Gladys, for that. So before I get to where we are, just maybe a bit of a background about Nairobi in terms of the FIF Act. So before the national government actually passed on the FIF Act, Nairobi County was in the process of working on an FIF policy for the county to be enacted at the county assembly. Already Nairobi had seen the need for autonomy for facilities and for facilities to be able to raise and retain their finances. So we were in that, but the national government went ahead of us, but it still worked for us. So we were ready to go. So actually it was catalytic for us. So because why I'm saying that is because most of our facilities were already retaining the money. Our monies were not going to the county revenue fund. So we were in the process of coming up with a policy more for formalizing what was already happening in the ground. So in terms of domesticating, we've been able to domesticate, and we are now looking at the FIF Act and its provisions. So first things first, of course, if facilities are going to collect and retain their monies, we needed to ensure that all our facilities have bank accounts. So Nairobi has around 124 public health facilities. So we wanted to make sure that no one is left behind. So we started with opening bank accounts. And then when you look at the FIF Act, it comes up with some provisions around establishment of the CHMT, establishment, that is the County Health Management Team, establishment of the Sub-County Health Management Team. So that was already in place. But it also defines and restructures establishment of health facility management teams. When you look at different counties, you might find that health facility management teams in terms of membership may vary because we were using the MOH guidelines and all that, but there were variations among the counties. So the FIF Act now gives framework on how the health facility management committees will be constituted. So in Nairobi, we are still in the process of it, trying to, because there's a whole process of appointment and all that, making sure that now we are aligning to the provisions of the FIF Act. Besides that, now that facilities are going to retain their monies, we needed to ensure that they also contracted. Along the FIF Act, of course, there was the New Share Act. So we were working to ensure that our facilities are contracted by the Social Health Authority so that they are ready to access funding from the Social Health Authority. But besides that, we appreciate when you look at the provisions of the FIF Act, there are different sources of revenue for the facilities. So we are also working to ensure that they're also leveraging on other sources, including private insurance. So some of the facilities right now are currently being empaneled under Jubilee Insurance and all that. So just making sure that our facilities are ready and they're able to retain. So in terms of domesticating, 100%, all our facilities are collecting and retaining our monies. That's it, and back to you.
Thank you very much, Dr. Rebecca. Dr. Babu, Trans Nzoia's experience.
Thank you so much, Gladys. The journey, the Trans Nzoia journey is not very different from what is happening in Nairobi. But as Dr. Zaituni has said, we also had the Trans Nzoia County Health Improvement Fund, which act, that was created in the year 2021. Although we had not operationalized that act fully because we were still collecting the hospital revenues through a central departmental or county revenue fund. But now, currently, with the passing of the FIF Act of 2023, all our facilities in Trans Nzoia County now have their own bank accounts. They are collecting their own revenues. They are budgeting their own revenues and spending their revenues at the collection point. One of the issues that we are grappling with or maybe one of the issues that we've not been able to solve, much as we have adopted this national FIF Act, is we have not been able to decide, like in terms of how much revenue we are going to send to primary healthcare activities and what will be retained by the facility, because the national act says 100% of that money is supposed to be retained in the facility, and we know very well that there are other primary healthcare activities, especially for a county like Trans Nzoia that has very, very well established primary care networks that might require some support from some of the facilities that are linked to the primary care networks. So those are the things that we are still having conversations about, but I think we have taken a step in the right direction.
Amazing. It's interesting to note that both counties had already started implementing FIF before even the act. So it's just a continuation of a system that was already running, and that's quite impressive. And I think the next question ties to the service delivery changes that you're observing as a result of the FIF. So what is that you've noticed at the facility level that has improved or changed as a result of facilities being able to retain their own revenues? Dr. Rebecca?
Thank you, Gladys, for that. And before I just jump onto that, also say we are also in that scenario as Trans Nzoia when it comes to, you see, the FIF Act establishes, I just mentioned, the county health management team. It establishes the sub-county health management team. Besides that, we know for us to achieve UHC, there is need to PHC, and PHC is very related to the community services. So we're also grappling on how to be able to support community services and also CHMT and SHMT functions, because you can already see the act has given duties of these functions, but they need to be enabled. So we are also in the process of working on FIF guidelines. We appreciate that the Council of Governors has come up with model regulations for that. And we're also trying to see how we can ensure that all these different functions are supported. In Nairobi, we have around, we had 10 out of 17 primary care networks. And that is one of the issues that come. How can we support the PCNs in terms of service delivery? So what have we started to see with the domestication of FIF Act? One of the main sources of facility improvement financing is actually the Social Health Authority funding. And for our facilities, we have around 108 primary healthcare facilities that are drawing funds from the primary healthcare fund. With the introduction of the SHARE Act, we are seeing our primary healthcare facilities now, which is a performance-based method of reimbursement. We are seeing our facilities starting to claim from the Social Health Authority. Before, with the previous system of NHIF, you know how NHIF used to pay for outpatient services. It used to be people used to select facilities, and our facilities suffered what we refer to selection bias in terms of they are not selected. But now with the new performance-based method is you're awarded on a monthly basis. You receive reimbursement based on the services that you've been able to receive. So that has been an incentive, and we're seeing increased claims by our facilities, both level 2 to level 5, to all the funds in the Social Health Authority. So we are seeing increased revenue. And for some of the facilities, let me just give an example of a level 2 facility. They're saying we were not getting any monies from the previous National Health Insurance Fund. We were not getting any monies because we were not contracted for outpatient services. We were not receiving capitation, and we didn't have maternity services, and also we don't have inpatient. So for them, it's a story of coming from zero monies to some money. So we are getting revenue. So from coming from zero to something, it's very significant. So just a facility getting revenue, and others that we're already getting money from the previous NHIF, we are seeing increased revenue generation. None of our facilities, like Kangemi was saying, we only used to get around 15,000 Kenyan shilling for outpatient services because of the people that we were seeing. But we had a very high workload, but getting just very few monies for outpatient because not many people had selected them. So we're seeing such a facility now being able to come from 15,000 per quarter to up to sometimes 2 million, 3 million shillings per month. So increased revenue. Also, we did a survey sometime last year to just understand what is the experience in the facilities. So the facilities were saying They are seeing increased workload, they are seeing increased availability of commodities and a more engaged workforce. And when I mean a more engaged workforce, we are talking about the casuals, because right now our primary healthcare facilities will contract casuals. They are able to pay the casuals, and then the facility in charges, one actually told me, we feel like right now we can be able to lead, we are able to make some decisions, and small things like sometimes you run out of emergency medicine, but you didn't have any money and you were not able to come. So increased and a motivated workforce and a very engaged workforce that is working towards increasing revenue in their facility to improve service delivery. Thank you.
That is impressive. Increased workload, increased commodity availability, better HR staffing, and a motivated workforce. I think that sounds like a recipe for a very good health system and operation. So over to you, Dr. Babu.
Yes, Trans Nzoia County has witnessed an increase in the motivation of the health workforce, largely because of a more strengthened hospital management team. Because the hospital management teams currently are owning these hospitals, they are owning the decisions that are being taken, and they are able to decide what is a priority to any of the hospitals within Trans Nzoia County. This one has been very, very useful because now facilities are deciding what they think they need to prioritize at any given point. And I'll give a case in point of our county referral hospital, which at some point was operating without a HMIS. But because of the FIF Act, and now the HMT came up with the idea that they need a hospital management information system, they were able to do this, budget this, and also establish this HMIS without really any support from any other external source of income. We were also excited with this because now our stock rates are much higher. We have a county dashboard, which is interestingly supported by, which was developed and supported by Hector. And this dashboard, we are looking at our stock rates. Initially, we were ranging between 30 and 40%. That's stock rates for commodities. Currently, we are averaging at between 60 and 70%, which is a very good thing because decisions are being made faster, especially in terms of the emergency medications. And sometimes they would just be the usual medications we need, but the decision to get those medications from the time approvals are sought to the time we have the medications or any other commodities in our stores was long, but currently it is so shortened. And these decisions can basically be made at the hospital management team level and forwarded to the hospital board for approval. So it is a game changer for us, and I think we are doing much better than we were a few years or months ago.
So both counties again have recorded the same gains from FIF Act, and it's quite impressive. But I love that you've mentioned in the point on responsiveness of the facilities to emerging needs. I think that's something that needed to be addressed, and the centralized system that we had before made that a bit difficult for facilities to do. So that's a very welcome change, and we can look at the other side of the coin and ask, what are some of the challenges that you faced in terms of implementation of the FIF Act, and have you been able to resolve these challenges, and how have you done that?
Yeah, some of the major challenges we've witnessed with the FIF Act, you see, we are heavily relying on the share reimbursements to run our hospitals. So a lot of times we might look like we have a lot of money on paper, but not all that money is coming to the facilities. Trans Nzoia County belongs to some of the counties whose pay rate is between 50 and 59%, meaning for every 100 shillings we incur to give a service, we have largely received just between 50 and 59 shillings. So we are still owed a lot of money by the Social Health Authority, and that one is slowing services to a large extent. Because sometimes we end up seeking support from the county or the departmental level to restock commodities. But had we been able to have all this money, the money that is on paper, most of these services would have been able to run seamlessly. The other issue is that we've been unable, and I've mentioned this before, we have not been able to agree on how we are going to split this money, the money that is supposed to go to primary healthcare services and the money that is supposed to be retained at facility level. Because when you look at the National Act, it talks about retaining 100% of these monies at the facility level, but yet there are other services that need to continue running. For example, the primary care networks, and Trans Nzoia County happens to be one of the counties in the country that has gazetted all the 5 primary care networks, unlike other counties that are still trying to gazette the primary care networks. Lastly, we have also not been able to see whether these funds can flow in the correct way. Apart from just the delay, we are not getting the money at all. And lastly, the claims. We have also had problems in terms of the claims, because it is only proper claims that will be paid. So our workforce is still being trained, and there are even facilities up to date, about 2 or 3 facilities that have not been doing the correct thing, and we are working on it, and therefore their claims and reimbursements have been much lower than they should be. Thank you.
Thank you, Dr. Babu. Dr. Rebecca, what has been the Nairobi County experience?
Similar challenges to Trans Nzoia. Of course, this is a new act, leveraging mostly under the Social Health Authority for facility improvement financing. So a lot of teething challenges, especially from Social Health Authority. Last year as a county, we just said we are going to put focus on our primary healthcare facilities to ensure, as I mentioned, some were not receiving monies before, so they were really struggling. So we said we'll put all our efforts to our primary healthcare facilities. Nairobi is very big, 10% of the country's population. So we have a lot of needs, and we wanted to see how we can support our PC facilities to work. So the whole of last year, we were helping them open accounts. Some didn't have accounts. Also getting those accounts to the Social Health Authority, it was a lot of work. It was actually a lot of hard work. You'll find that sometimes the Social Health Authority will say that there's a name mismatch and their money will be held. Again, MFL code, that is a unique identifier of a facility. So we've had a lot of challenges in terms of getting our facilities to start accessing the monies. But towards the end of last year for our PHC facilities, we were at 90%. We are down to 85%. They have just paid October. We're also experiencing delays. The payment provider model should be every month. Right now, the national government for our primary healthcare facilities has paid up to October. So the delay is also affecting cash flow, which will eventually affect service delivery. For our level 4s and level 5s that are also drawing from the Social Health Insurance Fund, our payout rate is not doing so well. We are currently at 45%. So this year, that is what we are putting focus on to ensure that we can get them from 45% to 80%. At least at 80%, they'll be able to have good cash flow and ensure that they are running their facilities. So teething challenges and our allocation of monies. Facilities are also saying they need guidelines. Now that we've received the money, can we get guidelines? How much goes to drugs? How much goes to this? And then again, how do we support the various functions, as we said? Yes, so those have been the key main challenges we've experienced. Thank you.
Thank you very much. I find the extra reimbursement issue to be quite interesting, because this is a similar challenge that we had under NHIF, but we extend a bit of grace given that it's a new rollout program and see how things turn out over time. And a question is, you've both recorded very good progress in terms of your FIF Act implementations, and we've seen you had also made attempts at doing this previously. What have been some of the factors that have enabled or driven this kind of success that you've had in terms of your FIF Act implementation?
For Trans Nzoia County, the biggest advantage we've had is a motivated workforce, and the workforce is really determined to make sure this works, because they know that they are now in control of their facilities. They are able to decide the fate of their facilities, because they are likely to know what is more important to that facility than any other person working in that space. We've also had very good support from the county leadership in terms of ensuring these facilities have gadgets, in terms of ensuring we have human resource, and also in terms of ensuring that we sensitize our people to register for SHA. We've also been able to mobilize the communities through through community health promoters, to be able to register as many people as possible into SHA, so that we have as few people as possible paying out of pocket from the communities. A lot of the people within Trans Nzoia County were paying out of pocket, and because of this, we're even seeing much less cash collections in our facilities, and most of the people are actually paying through the insurance. So that has been an advantage for us.
Thank you
Yeah,
very
and
much,
to
Dr.
just
Babu. Yeah, go ahead.
Sorry, Gladys, I was just jumping in.
Yeah.
Similar to that, I think for us, our major enabler has been the leadership. We have seen an engaged leadership from the office of the governor to the office of the county executive committee member, all the way to the facilities that have been engaged. As I was telling you the story about our facilities and trying to ensure that they are getting monies. As I was doing the follow-up at the county supported by the county executive, our in charges will also go to SHA and also make sure that everything is working. So all of us were united for one focus. So it is that engaged and motivated staff and leadership that has been that has made all the difference for us. And one of the things that I also want to mention, we've seen, I did mention about engagement. Now we have seen also facilities thinking beyond the facility improvement, the social health authority, because there are different sources of facility improvement financing. So some of them, like recently, I just wanted to mention this story of Mbagathi Hospital. They got motivated because of that engagement. They've just received 100 million grant from the Safaricom Foundation, and this was led at the facility level to be able to support their maternal services. And they'll be having a maternal and child unit, because they also realize as much as we are getting these monies, we still have a deficit. It's something, but it's still not enough. So yes, so again, engaged leadership, engaged facilities. Back to you.
Awesome. Leadership and a very motivated workforce. I think that's in extent to due to the fact that they're able to retain the revenue and have some form of control over what they actually do with the revenues and meet their needs. I will cross over to some questions that are coming through for the panel. And Dr. Rebecca, the first one is to you. So there's a question there is a question on the fact that we are observing frequent health worker strikes across different counties. And the question is, how will the facilities or the health departments continue to generate revenue if we keep recording these numerous strikes that are happening across the country and across the counties?
Yes, very, very fantastic question, because actually today we were training some staff and we were looking at our performance since we started, and this was just focused on our primary healthcare facilities. And we realized by the time we started in January, we were at 56 million in terms of our global budget, what we got as our public facilities. We had doubled that amount in September. But in October, we had a dip, and I was asking them, what do you think caused this? And the dip was definitely because of the staff, the strike. So that has already affected. So we already seen the impact of that. And as we engage the leadership, we're also hoping that we can get amicable solutions to this, because the strikes are impacting, and it's so clear. We already projected, we had a number in which we were like, by the end of the year, this is what we are going to make, but we are going to get a shortfall because of the impact of the strikes. But besides that, we are also seeing, as I mentioned, an engaged staff. We are also seeing some facilities because at the end of the day, it's performance-based, that are using now the facility improvement financing to contract staff to ensure that services continue and they are still able to mitigate. But you see, that is a cost that could be avoided, because now they are spending money on human resource, and perhaps they could have increased their allocation on commodities. So that is something, of course, above my pay grade, but with the data we can use, to lobby, because it's affecting our revenue. Thank you.
Thank you very much, Dr. Rebecca. Dr. Babu, so there is a question on the fact that the FIF Act at the national level states that the revenues generated by facilities should be a supplement to the budgets and the resources that they've been appropriated by the county government. Is this the case? Are you still supporting your facilities with monthly, quarterly allocations from the county budget?
Yes, Gladys, thank you for the question. We are still supporting our facilities from the county treasury kitty. It might not be directly in cash, but we are supporting these facilities in terms of drugs, non-pharmaceuticals, and even laboratory equipment and reagents, because there's a departmental budget for these. So we are procuring some of these commodities centrally and distributing them, especially to facilities that are offering primary healthcare facilities, since their collections might not be as good as the larger facilities like the level fours in the county. We are allowing the level fours to try and procure these on their own, although they still have a lot of support from the departmental level. And interestingly, this week we've been having a discussion with the members of the county assembly. We are actually on a retreat right now to see whether they can increase the financing of or the allocation of resources to the health department. We are hoping that they increase the budgetary allocation for the health department, which currently stands at 26%, and a conversation is in high gear to push this to 33% so that we are able to continue supporting these facilities in this way.
Amazing. So in practice, it is indeed a supplement to county allocations and support. The other question coming in is if it ties to the fact that we've mentioned that we need to finance other PHC related activities, including the PCNs. And the question is, if community units are linked to primary care facilities, why can't the linked facility meet costs for primary care activities in their designated community units from the reimbursement that they get? Can the facility management make such a decision? Dr. Rebecca, I can allow you to go first on this.
Okay, thank you, Gladys, for that. And just to reemphasize around the previous question about the amount being a supplement, it's true. Just to give a very a picture of Nairobi, when we did our annual development plan for the county 2025-2026, the health department, the health sector needs around 36 billion from the county, that is from the exchequer and from the county on-source revenue. We get only around 10 billion, which is around 25% of what we need. And that allocation is like 25% of the county's budget. So while there is facility improvement financing, what you're saying that it's a step in the right direction, but it's still not enough. So even besides the allocations by the counties, we're also asking the national government whether the counties, we could increase, there could be an increase in the equitable share, because when you look at it, counties are like Nairobi is giving up to 25% of its budget to health. So it's a step in the right direction, but it's not enough. It will not be able to cure our fiscal deficits. And the question around how we can support community units. So what we are seeing on the ground is, yes, these community units are linked to primary care networks and they are linked to facilities. So at the moment, our facilities are actually being able to budget for activities being done in the community, for the community units that they are linked to. So that is being done, but there's no framework because we are getting different sub-counties, different facilities allocating different amounts. So there is need for framework and guidelines to be able to guide that. Yes, so that will be my take. So what is happening right now is not really formalized, but we are not saying that they're not being supported, but it's more of a workaround. Thank you.
Thank you very much, Dr. Rebecca. Dr. Babu, did you have something to add on that?
Yeah, it is much similar to what is happening in Nairobi. Initially, as a county government, we had tried to be supporting these primary healthcare activities from the departmental level, where we had decided that a certain constant figure will be given to all the PCNs in every financial year. But it began looking like it's unsustainable, especially when the PCN activities began being more active than we thought they would be. So we opted to have these facilities, this PCN, be supported by the facilities that are linked to them. And as Dr. Rebecca has said, we do not have a framework for this. Every PCN is having different figures, and some of them are even not collecting enough revenue to support the PCNs. So we are back to the drawing board, and these are some of the things we really need to have a discussion about.
Thank you very much, Dr. Babu. And Dr. Rebecca, a question for you. How is the primary care network health management team in Nairobi supported?
I think that fits to the same question. We said we have no framework around that because the monies based on the Act are meant to be retained at the facilities. So we are still trying to come up with a framework in which we ensure they are supported. But right now, the facilities that are under the primary care network budgeting for the activities under the MDTs, because we have what we call the multidisciplinary teams that are constituted at the sub-county level to ensure that they are supporting county activities. And what we are seeing is the MDTs are working closely with the facilities to go out for outreaches, for in-reaches, and they budget together for these activities. And it works for both. It works for the community. They're able to meet their goals. For the PCNs, they're able to meet their goals and the MDT. And what happens in the facility, as they go to the ground, they're able to register more people. And when we register more people, we're able to increase our global budget, that is for primary healthcare. Right now, Nairobi has 55% of its population registered. So we are already seeing a global budget of 183 million because it's 900 shillings per head for any person registered, which is 75 shillings payable monthly. So when we increase the number of people registered, when we are doing outreaches and inreaches, we're increasing our global budget. When we were starting last year, we were about a global budget of 100 million. So right now we have 183 million. And when we increase, the target given by the Social Health Authority is 4.9 million. We can get to a global budget of 350 million when we register everyone. So it's been catalytic as we go to the ground together. But again, we still keep on saying that we need a framework to be able to guide this. Thank you.
Well, I think that number has really stood out to me, the 55% registration status of Nairobi County. That's quite some impressive feat. And to Dr. Babu, there's a question for you. How was your experience transitioning from the county FIF to the National FIF Act? How long did that take? And were there any concerns from the county treasury due to the loss of control over health funds?
Yes, old habits die hard. But indeed, there was a lot of difficulties when we were trying to transition. But the good thing is that we are law-abiding citizens, and we kept reminding all the players of the law, because we might say so many things about what is supposed to be done, but when we have the law with us, a lot of those things will have to work the way we expect them to work. That resistance was not only maybe from certain quarters, maybe the leadership or anything, but even from the staff themselves. There are people who are in charge of certain things, and they thought if we do away with this, maybe they lose control of what they were doing. So indeed, we stood firm with the law, and that is how most of those facilities had to open bank accounts so that they begin running and monitoring and managing their own resources. But it was not a very easy journey. It took close to a year and 8 months for us to transition. In fact, we had to, there was an audit query that was raised by the auditors the year before we fully executed this. They were wondering why we have not transitioned, but it was because of some of the logistical problems, including some facilities not having their own bank accounts. But we heavily relied on the audit queries to also advise the county to make sure that we transition as fast as possible, because we are already raising questions with the Auditor General.
Thank you very much, Dr. Babu. 1 year, 8 months, and all habits do indeed die hard. So it's impressive that you were still able to get momentum on that as well, despite the concerns that were coming up on loss of revenues, which are also quite valid because it really was significant revenue for the county treasury. And I think our last question coming in, and where with the rosy experiences that we are seeing in terms of improved revenue collection at the facility level, why are some facilities still struggling now with persistent commodity and supplies stockouts? I think I can direct that to both of you, and then we can wrap up with one final question.
Yeah, I think that is largely because of something we have already tried to mention here, is that we have a lot of money on paper, but not most of that money is coming back. It's coming to our accounts. Therefore, we do claims, but still most of that money or a good amount of it is not paid. So we end up really struggling to get these commodities. And also, we are not able to procure some of the services. Ideally, with this, with a very functional FIF and a good cash flow. In fact, in times where we have some severe shortages, we are supposed to be able to even get some staff. We can be able to get some staff and support them through a hospital payroll. But now that one has also been very difficult because the money is not just coming the way it's supposed to come. That is the main reason why you are seeing some hospitals having very low stock rates.
Yes. And just to add on that, yes, that is also the case of Nairobi. As I said, for PHC, our journey, we started at 10% of our facilities accessing money. That is around March last year. Close towards December, we were at 90%. So there's a 10% of facilities that are still grappling with issues around access of their money. So you don't expect those facilities to be able to stock. And then again, timeliness of payment is also affecting that. While it's a good initiative in practice, but sometimes the delays really hamper that. But besides that, as a county, this year we are shifting focus to performance management to ensure that, because it's not, we are saying it's 10% that are struggling, the other 90% to ensure that now that you have money, that you are prioritizing your allocations to drugs and to improving service delivery, because there's the need of now monitoring, supportive supervision and all that to ensure that the facilities are also meeting their end of the bargain. Yes.
Amazing. Thank you very much, Dr. Rebecca and Dr. Babu. And I think we want to end this in terms of being futuristic and having drawing on the lessons that we've learned so far. And so, based on your experience so far with the implementation of the FIF Act, what is the one policy or system change that you would recommend to strengthen the impact of FIF moving forward? For all counties, for Nairobi, for Trans Nzoia, you can choose the context that you'd prefer to respond to.
I would say we need to relook at how we want to finance the whole of this healthcare system. Because one of the things that we are struggling with is many of our people might not be able to afford paying all the money that they are supposed to pay for them to access SHA in our hospitals. Of course, for primary healthcare services, they don't even need to be paid up members. All they need to do is just register. But now we are ending up being unable to provide these services under SHA. Because many of these people are told maybe in a year you need to look at to pay maybe 15,000 or so shillings, 10,000, but these people are not able to pay. So we end up providing some of these services and we will not be reimbursed or will not be paid by anyone anyway. But of course, we are very unlikely to send away these patients if they come to government facilities. They are likely to still get the service and then they'll be released on a waiver, or sometimes we just allow them home because it becomes very costly to still keep them in the hospital because they cannot pay those bills. I think that one will really help us. And from my perspective, I also feel like maybe the social health authority, I know that is a completely different entity, but it's the one that is affecting facility financing mostly, especially in the public facilities. Perhaps they're not just collecting enough revenue for them to keep reimbursing hospitals. We need to find another way in which we can make sure we bring more people on board who are paying, because right now it's heavily relying on the employed workforce, and yet that is just about 4 or 5% of the entire population. And the informal sector, we've not designed a very good way of collecting the SHA reimbursements, because there are even people who could be domestic workers, for instance, who are being sent money by the owners of those four homes. I will use the example of Trans Nzoia County. Some of these people are like they are farm workers, but the owners of the farms perhaps don't even live there, but they send them money monthly maybe to run the farms, to keep the homes neat. But now, when we are doing the means testing, when we want to decide what someone will pay, a domestic worker whose monthly pay is about 10 to 15,000 shillings is being told, because of their M-Pesa statements and the means testing tools that are being used, they are now expected to pay a yearly subscription of about 30,000 or 40,000 shillings. So those are things that are making it impossible for us to include as many people as possible so that we generate as much revenue as possible. Because if you are told from your means testing you need to pay 40,000, perhaps you'll just let it go and you'll not bother to subscribe to SHA.
Thank you, Dr. Babu. Dr. Rebecca, in a minute or less, then we'll have Dr. Zaituni respond as well.
Okay, so for me, the one thing is resources will always be limited. We know that. So we have said that the FIF, what you are getting, and you realize we are all talking about social health authority because that is the main source. 90% of our facility improvement financing comes from the social health authority. So the little that is coming, that which is coming needs to, we need to make sure that it's going out a long way. So it's more health for the money. So we need to come up with systems for performance management. And that's what that's our focus in Nairobi this year. So we call everyone who wants to help us do this to ensure that at the end of the day, it's not just about the money, that the money is able to help us achieve the UHC goals, that there is equity, that there is access, and that we are seeing positive changes in our indicator. Besides that, we need to, again, relook beyond the social health authority and continue the journey of alternative domestic resource mobilizing. What resource mobilization, what other vehicles that have we not considered or we have not optimized? As a county, we also know we've not optimized the social health authority and we'll be focusing on that. But what other vehicles that have we not considered? Research grant opportunities, the role of the private sector and such. So that will be my take, and back to you, Gladys.
Thank you very much, Dr. Rebecca. Dr. Zaituni?
Maybe the one thing that comes to mind from Trans Nzoia County, even after we have done all this, is that we need to ensure that we are fully digitized all the way from level 1 to the highest level of care, because most of the money is lost through possibly lack of claims. Most of the facility in the lower levels do not know how to claim, and if they do, they do not use the proper maybe set up system, which is due for implementation in Trans Nzoia County. Maybe it will help us to ensure that we have even more revenue collected. Thank you.
Thank you very much, Dr. Zaituni and Dr. Rebecca, Dr. Babu. Thank you for your engagement in this conversation. It really was a fascinating conversation, and I feel like if we would have had more time, we would be able to unpack some of these things a bit further, and we should probably consider that as well. It has been exciting to learn of your experiences, and I am quite impressed by the gains that we are making in terms of FIF. It does seem to be a step in the right direction in terms of attaining UHC and improving health outcomes at the community level, at the granular level, and that's quite impressive. I have been your moderator, Gladys Oshira, a research analyst from the Institute of Public Finance, and asanteni sana for being with us. I will hand over to Dr. Sally for her closing remarks. Thank you.
Asante sana Gladys for moderating the session, and thank you so much to our very able speakers for taking time to share your experiences with us, Dr. Babu, Dr. Zaituni, and Dr. Rebecca. We really appreciate your time. Thank you also to everyone who took their time to register and attend this webinar. So for the speakers, you've shared many lessons with us, but just a few I highlighted as having stood out. One, we've learned that the FIF Act just formalized and strengthened what was already existing as a practice within our facilities, where they still retained their revenue, but did not have a clear legal framework to do this. And we've also seen that the FIF Act helped to shift power to the hospital management teams, enabling them to set better budget priorities based on their direct facility needs. And we've also heard over and over again from both Nairobi and Trans Nzoia that this has led to a more motivated health workforce and more motivated managers who are able to be more responsive to emerging health facility needs. And we've also seen that the FIF Act in itself is not a silver bullet, and we require, as health leaders and policymakers, to keep thinking strategically about alternative resource mobilization to meet the county health deficits financially. And we've also seen having a hands-on and engaged leadership being a key driver for successful FIF implementation. In both counties, we've seen that the county health management teams have really come in handy to build capacity among the facility team members, strengthening their financial management capabilities along the existing national policies such as the PFM. And at this point, we also recognize that we have quite a number of county health leaders here, chief officers, county directors of health present, members of the COG. We really thank you for the work that you're doing, supporting the teams at the county level to ensure that FIF implementation and basically financial management keeps being strengthened in our counties. And also having the top leadership, Dr. Babu, Dr. Zaituni, and Dr. Rebecca, taking time to share their experience as well is just a show of really committed leadership where they strive to want to get better and also share their experiences so that we move together as a country. And we take note of the recommendations you've raised. One, that facilities should not have a lot of money documented on paper, but that does not reach the facility for utilization. That SHA should ensure timely reimbursement of funds to the facilities so that facilities can continuously have adequate revenue that they require for recurrent expenditure. And two, that counties should embrace performance management for them to be able to track revenue and expenditure and ensure resources are addressing the emerging county health needs. And three, that as counties, we should develop or adopt existing FIF regulations that guide how revenue is being spent at the facility level. And we thank the COG for providing model FIF implementation guidelines that counties can adopt. So thank you so much, first of all, to the organizers of this webinar, Hector Consulting, IPF, to the three speakers, and to all of us for attending. This is the first of a series of primary healthcare performance management webinars that we hope to be able to have every month. And we intend to have our next webinar in the next 1 month. We shall be sending out more information on this to your emails and on our social media platforms. So let's keep striving to draw more money to our health basket as counties and ensuring that the money addresses the prioritized health needs. And as one of the speakers here today, Dr. Rebecca, has put it, let's strive to have more money for value, more value for money, and more health for the money we have. Asanteni sana. Thank you.
Thank you.
Thank you.
Thank you.
Here.